Okay, everybody, we're going to start off so that we can have as much time as possible for questions. For those of you who don't know me, I am Stella Creasy. I am the Member of Parliament for Walthamstow in North East London. And like a lot of you, I'm also pregnant, which is why this is a topic which is of a particular concern to me. I'm really pleased that we've been able to do this today with Pregnant and Then Screwed, and the amazing Joeli Brearley is with us. I've only got 3 words to say about Joeli Brearley, which is buy her book, because it is absolutely phenomenal. We've pulled together a panel for you of people to be able to answer all the questions that we know people have about pregnancy, about COVID, and about the vaccine and fertility. Lots of questions we've seen circulating on the internet, but also about your experiences. We know during the pandemic, a lot of pregnant women have experienced discrimination in the workplace. We know there's been a lot of confusing information. So we're hoping this session is going to be really helpful in trying to explain some of those things. I'm delighted that we've got 2 fantastic interpreters with us today. We've got BB, who's interpreting for me now, and she's going to be joined by Francis later. But if there's anything that you find that you can't access about this session this evening, please do put it in the chat box. You'll see that we've already got over 1,000 people joining us this evening. Because we know everyone's got a lot of questions, we thought the fairest way to handle this was for you to be able to use the question and answer function, and then we'll look for the questions that get the most votes. So please do have a look at the questions that have already been posted, and please do vote for the ones that you want to be answered. Unfortunately, although we're going to try and make as much time as possible for questions, we're probably not going to get through everything. So please do help us prioritise in that way. We've got a fantastic panel for you this evening of experts to cover a wide range of topics on this issue. So without further ado, I'm going to ask our first speaker, who is Dr. Rehan Khan, who is an expert in fertility and medicine from the Barts Trust, to kick us off. And he's going to talk to us about, and everyone's going to give very brief speeches so that we can get to lots of questions, I promise you this, but he's just going to say a little bit about what we know about COVID and fertility, and also the vaccine and fertility. So with my seamless hosting duties on, I'm now going to swap faces with him and make sure that you can see him. And then, Rehan, if I can ask you to unmute yourself, please.
Thank you very much, Stella, and it's a pleasure to speak to all of you about fertility. So a question I get asked a lot is, should I have the vaccine for COVID-19 if I plan to become pregnant? And the most recent advice that we have is that for women who are trying to become pregnant, they do not need to avoid pregnancy after vaccination. And if you're in one of the groups offered the vaccine, getting vaccinated before pregnancy will help prevent COVID-19 infection and its consequences. So sometimes women will need to make a decision about whether to delay pregnancy after the vaccine becomes available to them. Another common question is, amongst women who are trying to get pregnant and have had the first dose of the vaccine, they're wondering, should they delay pregnancy until after the second dose? But actually, 1 dose of vaccination gives you good protection against infection, but it's probably not long lasting. And if possible, we recommend that you complete the course. But now on to the big question that everybody's been asking me, which is, does this vaccine affect fertility? There is no evidence to suggest that any of the COVID-19 vaccines will affect fertility. There's no biologically plausible mechanism by which any of these vaccines could cause any impact on a woman's fertility. Evidence has not been presented that women who've been vaccinated have gone on to have fertility problems. Likewise, the theory that immunity to the spike protein could lead to fertility problems is not supported by evidence. Most people who catch COVID-19 will develop antibody to the spike, but there's no evidence of fertility problems in people who've already had COVID-19. And of course, as more evidence becomes available on the safety of each vaccine, there will be more advice coming in. And as you'll hear from my other speakers, there are ways that we can signpost you towards the best evidence that we can. So I find that in some ways, this is one of the most emotive topics that as a doctor I have to try my best to answer. If you have a doctor or a midwife and you want to talk about things like this, just be open with them about your concerns. We're here to help, but especially we're here to listen and not to judge. in some ways, what I've got to say is the shortest part of today's short talks, because there really is not a link with fertility problems. So I'll hand you back now.
Brilliant. Thank you, Rehan. Thank you for also being very brief. We much appreciate it. Our next speaker is Dr. Viki Male from Imperial College, who is an expert in reproductive issues as well. And she's going to talk about how the vaccine and the virus affects pregnancy in particular. So hopefully I can add you as a spotlight. Perfect. Over to you, Viki.
Hello, yes, as Stella said, please call me Viki. I'm a reproductive immunologist at Imperial College London, and I've been tracking the safety of COVID-19 vaccines in pregnant people. Now, when we consider vaccinating anyone, we need to think about whether the benefits outweigh the risks. And it's no different if you're pregnant, but pregnant people might have different benefits and risks to non-pregnant people that we have to consider. And of course, each individual might have their own risk factors that play into that decision, which is why we recommend that everyone discusses their own situation with their own care team. But nonetheless, we can make some general statements. So let's start with the benefits. Well, obviously, the main benefit of getting the vaccine is not getting COVID. And this is actually a greater benefit for pregnant people than for other people of the same age and BMI and so on, because we know that pregnant people who catch COVID are more likely to need intensive care than if they weren't pregnant. We also know that they're more likely to have their baby early, and their baby is more likely to need intensive care than if they had been pregnant and they hadn't caught COVID. So to me, these are the most important benefits of COVID vaccination during pregnancy. But it's also worth mentioning that, sort of by way as a bonus, if you get vaccinated when you're pregnant, antibodies against COVID will cross the placenta. And based on what we know from other vaccines, we expect these to give your baby some protection once it's born. So those are the benefits. What about the risks? Well, the first thing to say is that we know that the vaccines are safe in animals during pregnancy. And from what we know about the types of vaccines that these are, we don't expect them to go anywhere near your baby. But formal trials of these vaccines in pregnant people have not yet been completed. So in humans, we don't yet have any of that very clean data where we're comparing an unvaccinated control group to the vaccinated group in order to make decisions about safety and efficacy. But what we do have now is absolutely masses of real world data, because lots of countries decided that given the benefits of vaccinating pregnant people that I've just outlined to you, they would offer them the vaccine. And they would track them very carefully so that if there was any signal at all that there was an adverse effect in pregnancy, we could stop the rollout. So in the USA, now 87,000 pregnant people have been vaccinated. Other countries are not so good at publishing the exact numbers every week as the USA is, but across the UK and Europe, it's also many thousands. And the warning systems that have been designed to look for safety signals haven't found any in this population. We know, by the way, that these warning systems work because they identified the very rare blood clotting syndrome that's sometimes associated with the AstraZeneca and the Janssen vaccines. So from all of this, if I were pregnant right now, which I'm not, but I have got small children, so that part of my life is not too far past, I think I would want to get the vaccine if it was offered to me. And this kind of calculus has also informed the official guidance about who should be offered the COVID vaccine, which I think Jo is going to tell you about in a moment. And I'll look forward to taking your questions later. Thanks.
Perfect. Thank you, Viki. I'm now going to bring in our third speaker for this evening, our third expert that you can ask questions to, who is another person from Imperial, Dr. Natalie Shenker, but she's also here from the Human Milk Foundation, and she's going to talk about what we know about COVID and the vaccine and breastfeeding. So hopefully, ta-da!
Hi, can you hear me?
I'm getting quite good at this now. Perfect. There you go, Natalie.
Brilliant. So it's really great to be here, and I'm looking forward to taking lots of questions later on. So I basically wear two hats. My day job is largely being a human milk scientist, and during COVID I've been really interested in responses of human milk to help protect babies in response to COVID, but also subsequently in vaccinated women. But my, I guess my evening and weekend job is the charity that I co-founded, the Human Milk Foundation, which operates services throughout England and Wales to provide screened donor milk, principally to very vulnerable sick babies in hospital when their mums are trying to establish a full milk supply, but also increasingly through COVID to families at home where breastfeeding challenges were being faced. So from an academic and medical point of view, any new pathogen, any new infectious agent that happens significantly affects breastfeeding, but also can significantly affect milk banking. We know milk banking services effectively closed down in the UK during the 1980s after the HIV pandemic. So there was a real impetus for us to make sure that we're on top of all of the related information about safety profiles, because safety always comes first. But what was really pleasing is that several studies very, very quickly showed that COVID was most likely not passed through breastfeeding, through human milk. And then the vaccines came through. Now, I also sit on the MHRA consortium on safer medications in pregnancy and breastfeeding. And that meant I was on the inside track for the discussions that were held about the licensing of the COVID vaccine. And this, I think, is where a lot of the confusion has come, because for 3 weeks in December, the vaccine was approved in the UK, and it was absolutely fantastic that the vaccine was approved so quickly. But unfortunately, it was felt at that time, out of an abundance of caution, not to allow lactating or breastfeeding women to access that vaccine. And this was in light of no evidence. The lactating women also weren't included in the clinical studies. Now, that was overturned after the FDA and the CDC in America decided to license the vaccine and enable pregnant women and breastfeeding women to choose to have it if they wanted. And subsequently, the European Medicines Agency and other national providers has enabled women to make that choice based on the available evidence. Since then, 2 studies have been published, one as a preprint, one as a peer-reviewed, showing that there's no evidence of any vaccine component passing through milk. And several studies have shown that antibodies form, the most recent of which looked at 131 different women and showed that vaccine antibodies were found in human milk from all of those women, which is really quite remarkable. And so there's increasing evidence suggesting a good safety profile, plus the yellow card reporting system, which in the UK is used to report side effects of any pharmaceutical, any vaccine that's developed and rolled out, hasn't really shown any significant spikes for breastfeeding women, and it has been collecting data on whether women are breastfeeding or not. So women are reporting side effects, mainly fever and feeling tired, but not necessarily lactation-related side effects. There have been a few women reporting that their supply has decreased, that they've developed mastitis, or that they've developed breast pain. And a few have reported children who've had rashes or a low-grade temperature, or even a bit of diarrhea. However, these numbers are tiny given the numbers of women being vaccinated, and it's likely that these events might have happened anyway. And this is really where I'm looking from the outside and really wishing we could get a study set up that formally looks at side effects of vaccines in women who are breastfeeding against a control population who aren't vaccinated, so we can really tell whether we're seeing any vaccine-related effects. But that's a study that we're hopefully going to be looking into in the next couple of months. So that's all I have to say, but I'm sure there's a lot I've missed out.
Perfect. So I'm just swapping over our interpreters, if people will forgive me for a moment. So hopefully this is seamless, or at least not too disruptive. Thank you ever so much, Natalie. I'm now going to bring in our 4th speaker, who is Dr. Jo Mountfield from the Royal College of not ostriches, I'm so sorry, obstetricians and gynecologists. I knew I'd get, please forgive me. It's been a long day already and it's only the start of the week. I'll just spotlight you there, Jo. Jo is going to talk to us about what the current guidance says and how, if you want to try and access the vaccine, especially in the light of the government announcement last week that now pregnant women would be able to access the vaccine, what that means for us. So over to you, Jo.
Thanks very much. I know absolutely nothing about ostriches, so I'm not about to start on that at all. I do know a little bit more about obs and gyn. I'm a consultant obstetrician as well as working at the college, so this is my day job. So yes, there has been a very welcome announcement last week that pregnant women can now be offered the vaccine. So the vaccine that they are going to be offered is either the Pfizer vaccine or the Mrna vaccine. They are not going to be offered the AstraZeneca vaccine. I thought it was probably worth just explaining why. You will have heard of the evidence around the blood clots. The first thing to say about this very rare complication, and it is very rare, is it is not the same as the increased risks that you have in pregnant, when any pregnant woman has an increased risk of getting deep vein thrombosis, clots basically. But this type of clot, the one associated with the vaccine, is not related to the fact that in pregnancy you get an increased risk of having sticky blood basically and getting a clot. This is an immune response related to the vaccine. So if you are pregnant, it does not mean even if you have an increased risk of getting deep vein thrombosis for whatever reason, it does not mean that you are at increased risk of getting these cerebral vein thrombosis, which is a different sort of thrombosis, is an immune response. It's your body's immune response causing this. And so it is not at increased risk if you are pregnant. So I think that's a really important thing to say, first of all. But the reason why that the JCVI have recommended Moderna and Pfizer is primarily because we have more real-world data, because that's the vaccine that's been given most frequently across the world, particularly in the United States, where there's quite extensive real-world data now about outcomes. So that's the primary reason that Pfizer and Moderna have both got more data, and therefore they're going to be offered. And secondly, as you know, as you will probably be aware, that if you are in the younger age group, so your risks of COVID are less, and that applies if you're pregnant or not pregnant, the JCVI have suggested that you don't access the AstraZeneca. So, and that applies for younger women as well. So the two vaccines that have been, that you could be offered now are Pfizer or Moderna. And that has changed. Previously, if you were in the high risk group, so if you're in a high risk occupation, if you were a carer, if you had extra risk factors in pregnancy, particularly high risk factors, so for example, you had a significant heart disease or significant respiratory disease, you would have a conversation be offered a conversation with your obstetrician or GP about whether you wish to access the vaccine. Now, all pregnant women can be offered the vaccine. However, the logistics of how this is going to happen, the JCVI are doing this basically on age. So as the age range comes down for the general population, then women will be offered, who are pregnant will be offered those vaccinations. So if you're pregnant and you're over 45, you can now, should you wish to, access the vaccination. And that will, the rollout will happen along with the rest of the ages. They have not prioritized pregnant women above those women that are not pregnant. So the other thing I would say to you is this. Because particularly the Pfizer vaccine is more difficult in terms of its delivery because it has to be kept at -70°C. That is mostly happening in hospital sites. And therefore, although there's a large rollout of vaccination programs, many of those vaccination sites are not set up to give Pfizer and Moderna. So there will need to be some thought about how pregnant women can access those particular vaccinations. And I'm also aware that in order to have vaccination, you have to have a doctor to prescribe it. And they have circumvented this by doing something which allows other professionals to give that, but it has to go through a specific process. So in some hospitals where nurses are primarily giving the vaccine, it has not been allowed for them to give pregnant women vaccines. So that all needs to be changed. So there will be a little bit of a delay while the operational side of things catches up basically with the advice that came out last week. I think I've hopefully covered what I needed to cover. I'm really happy to answer any questions as well, but I'll hand back to Stella now.
Thanks, Jo. And that's the first time I've felt comfortable about the idea of being called a geriatric mother, if it means that I get access to the vaccine a bit quicker. Just to let everybody know, we're about to come to our final speaker, and then we're going to go to our question and answer session. You've all been brilliant already about voting for which questions you would like to see being prioritised. Can I really encourage you to have a look through the list and to like the ones that you particularly want to see answered, so we get a sense of what you really want to get out of this session, and Joeli's going to lead that. But our final speaker today isn't from a medical, but is from a legal background, because we are also very conscious, and I mean, the reason why you should buy Joeli's book is because the work that Pregnant and Screwed have been doing in the last year to make sure that pregnant women are not forgotten by the government in the pandemic has been extraordinary, because we know that pregnant women have been at the forefront of many of the discrimination challenges prior to COVID in our workplace, but they've been particularly exacerbated. So we've got Danielle here from Gorvin Solicitors, who is an expert in pregnancy and maternity discrimination, and she's just going to say a little bit. So if you've got questions for her as well, don't forget we've also got a legal expert here for you. But I'm hopefully going to add Danielle, perfect, and then take myself away.
Evening all. As Stella just said, I'm slightly different to the other speakers, and I'm going to try and keep this as brief as I can, because we could probably speak all night about whether or not employers can impose a vaccination on employees. I think the long and short of it is, at the minute, there is currently no legal requirement to have the vaccination, and obviously it's not commercially available, so we've got no control over who can access it either. So at the minute, no one can be forced to be vaccinated. However, as you can imagine, there's been much debate about whether or not people working in certain sectors, such as the healthcare sector, should be obliged to do so. The Chief Medical Officer, Chris Whitty, has actually said that he believes that healthcare staff should they're actually under a professional duty to be vaccinated, and that's been backed up by various medical organisations as well. However, I don't think that that is enough to kind of override the health and safety laws that are in place. And the reason for that is because where an employer is asking and saying that there's a requirement to be vaccinated, they are in effect imposing a medical procedure on employees. So I think employers are going to have to be very, very careful and tread really carefully about imposing this on staff. It's going to be very hard to impose, especially when the data on the transmission and the long-term immunity following the vaccine is so uncertain. Both the government guidance in the area and the guidance from the Health and Safety Executive as well recommends that wider measures should be looked at over and above the vaccination for making workplaces COVID secure. None of their guidance includes compulsory vaccination. So the government guidance makes it absolutely clear that the vaccination of a workforce has no impact on whether or not that workplace is COVID secure. And there are other guidelines that employers should look to follow. Likewise, the Health and Safety Executive provide massive emphasis on risk assessments being done in the workplace. And there's lots of guidance on their website about what should be included in that sort of risk assessment. There's even a template there for employers to follow, but even that template doesn't provide for compulsory vaccination. What the government and the Health and Safety Executives say that you should do is look at other workplace controls. So is your employer making sure that social distancing is taking place? Are they frequently cleaning the office or your workplace? Is there adequate ventilation, good hand hygiene? I think something that strikes a chord with me is that the Health and Safety Executive do say that they will not be responsible for enforcement in relation to vaccinations in the workplace. And that falls in line with workplace testing and face coverings as well, that employees obviously do have some control over. So to sum up, as I said, I think it'd be very, very difficult for employers to impose compulsory vaccinations. They must first carry out a risk assessment. They're going to have to consult with employees about whether or not vaccination should be rolled out. And one thing I will just mention just before I finish up is obviously there is massive discrimination issues here, and that's something that's going to have to be in the forefront of a lot of employers' minds. We found it a lot with pregnancy discrimination. Obviously, pregnant women were really, really worried about having the vaccination anyway. A lot of them were being told that they shouldn't have it, as many of the speakers have already said. And in that case, for an employer to impose a vaccination on a pregnant woman would have been discriminatory. Likewise, there might be issues with sex discrimination, because more women, it's been obviously documented in a lot in the press about how women are more at risk, for example, from the AstraZeneca vaccination. There's also disability consequences. Some people may not be able to have the vaccination due to conditions, and there'll also be a lot of speculation and a lot of emphasis around religious and philosophical beliefs as well. So as I said, I think it'd be very, very hard for an employer to impose a vaccination and also to ask for evidence of vaccination as well, due to all those concerns. I'm here to answer any questions, as Stella said before.
You're on silent. Stella, you're on.
Sorry, I managed to mute myself, a task and a skill that many people would wish I would practice on a more regular basis. I'm now going to bring in the fantastic Joeli from Pregnant Then Screwed, who we're doing this event with jointly, to lead the question and answer session. Just for people who are asking, if you can't see the question and answer session, so where you should post your questions, please don't post them in the chat box, please post them in the question and answer session, is on the screen at the bottom, and it says Q&A. And if you look in there, you'll be able to see which questions have been posed and which ones people are voting for to be answered. And that's what we're leading off. I'm also just going to swap over our interpreters before I bring in Joeli as well to lead this for you. So if I could just bring him back in, BB. Brilliant. And finally, last but not least, the amazing Joeli Brearley. Okay, over to you, Joeli.
Okay. So the first question I will pose to Victoria, there's quite a few questions on here about what we know about whether the vaccine has any effect on the baby. So there are 90,000 pregnant women who have had the vaccine and showed no safety concerns, but do we know anything at all about whether there are any theoretical long-term risks to the baby?
Well, I think we can start off by saying that a lot of those people who've had their vaccination while they've been pregnant have actually already had their baby, because, you know, in the US they've been vaccinating since December, and some people who were pregnant in December have now had their baby. But of course, we don't yet quite have people who are vaccinated in their first trimester having their babies. But what we do have is people in their first trimester having their scans, their first trimester scan and their anatomy scan, and no concerns seem to have come up with that. So that's the best real world data that we have. The question that we might then ask ourselves is, do we expect anything to happen theoretically? And I explained to you before that both with the RNA vaccines and the adenovirus vectored vaccines, which in the UK is the AstraZeneca vaccine, which actually won't be offered to you for reasons that Jo explained, we don't expect those to go really anywhere near your baby. So the only thing that could possibly happen is if your immune system did something. Now, of course, your immune system is supposed to do something in response to a vaccine. That's kind of the point. And the one thing that people do sometimes worry about, and I'll actually ask Jo about this in terms of ARCOG's advice, is we do know that if you have a very high fever for a very long time in the first trimester of pregnancy, that can be associated with problems. It's really, really rare to get a very high fever with these vaccines. Most people who get a fever get a little one, a mild one. But just to be safe, what the American College of Obstetricians and Gynecologists recommends is that people should take paracetamol if they're getting a fever following the vaccination, if they're pregnant. Now, we have only just moved over to a situation where we're going to vaccinate a lot of pregnant people. So I don't know in the UK if we have that really, really clear advice from our College of Obstetricians and Gynecologists like they do in the USA, and maybe Jo can comment on that. But what I would like to say is that we know that if you give pregnant people paracetamol to bring down their fever in the context of an infectious disease fever, it reverses any problems. So I think that that's the only thing that we might expect theoretically to be a problem, and we can very easily tackle it with this over-the-counter medication that's safe in pregnancy and that won't stop the vaccine working. And maybe Jo can comment now on whether RCOG has some official advice on that.
Great, thanks Viki. Jo?
We haven't as yet updated our vaccination data. We might have just about done it, given the short timescale since it was announced. But that is all really sensible advice. So we know paracetamol is a very effective drug at reducing temperatures, and certainly our advice around actually if you have COVID is actually as well to reduce your temperature by taking paracetamol if that is a problem. So it's not up on the website yet. In fact, it's a really good question, and I will feed that back to the team who are updating the guidance, almost very frequently, just to say it'd be really helpful to have that with clarity sitting on the website at the moment. But yes, it's really good advice. Absolutely, take some paracetamol, try and keep your temperature down if that's a particular problem for you. But for most people, it will not be a problem. You won't get a very prolonged high fever with the vaccinations, but it is a known side effect.
Joeli, something that Jo has said has just reminded me of one more thing that's really important to think about when we're talking about long-term effects, and that's this. One thing that will have a long-term effect on your baby is if it's born too soon, and we know that that can happen as a problem if you get COVID. And we also don't know yet what the long-term effect on your baby is if you catch COVID. And I know that some people are actively studying that to scan the brains of babies of women who've had COVID when they're born. So don't forget that there's also the potential for long-term side effects of COVID too. Don't just think about long-term effects of the vaccine. Think about the long-term effects that could be on both sides of these equation. And I have to say that for me, because of that known long-term effect that you might get in terms of disability if a baby is born too soon, I would say that from a long-term point of view, again, I favour vaccination.
And just to add to that, Viki, because we have got a question here, which is quite a bleak question, but and I know there's been lots that we have discussed during this about the impact on the mother if she contracts COVID while she's pregnant, and there is research that shows you are more likely to end up in intensive care. Do we know about the percentage of pregnant women who have tragically died as a result of COVID-19?
So I think Jo's got her hand up because I don't have those figures to hand, but it looks like Jo does.
So the UCOS data, which is the data across the whole of the UK, basically tells us that the rate of death for mothers is 2.2 per 100,000 maternities. So actually the risk of death if you are a mother is not dissimilar to that as if you are the similar age to matched age controls. So interestingly, although you are at increased risk if you are pregnant at ending up with an ITU, we think the reason for that is partly due to the fact that the threshold and needing that support is more in pregnancy, rather than it is more likely that you're going to die as a consequence of it, if that makes sense to people. So we can be reassuring about the mortality. Yes, there is a mortality associated with this, as there is with the general population, but it's actually really low in relative terms when you're looking at the wider population. So and I think that's a really important message. And as I say, the admissions to ITU, we're keeping a close eye on. Yes, they were increased, especially with a new Kent variant. There seem to be more respiratory problems associated with that. But we just don't know whether that's because there's been a much wider infection across the whole age range of the population. And we have a lower threshold as well for admitting women to ITU, because of obviously we have both a baby and mother to think about as well. So there are all those complexities around it. But for most women, please don't think that most women are going to get seriously unwell. Most women are asymptomatic. Most women, if they get it, have a cold or a flu-like illness. They do not need a hospital admission, and they do not get seriously unwell for the majority. So please hold on to that fact, because I think that's really important to say as well, not to raise too many alarm bells about this.
Okay, thank you, Jo. So that I don't keep coming to Jo and Victoria, Rehan, could you tell us a bit about what gestation might be the best to get the vaccine if people want to make that choice about gestation? And do we know if there's a difference in gestation and how the vaccine affects you?
We don't have any evidence that which gestation you have the vaccine would make a difference to how well the vaccine works, nor to what its side effects would be. And so therefore, the vaccine is considered safe in all trimesters, the three trimesters of the pregnancy, first, second, and third. It is worth bearing in mind, though, and I'm a doctor, I'm a human being as well. If there's a time in a pregnancy when people in general feel cautious, it is the first 12 weeks. So I'm not sure if there's a medical rationale at all to not have a vaccine in the first 12 weeks. In fact, I'm sure there isn't. But people feel cautious at that time. So what I want to emphasize is a decision to have a vaccine just before pregnancy or during pregnancy has got to be based on a conversation and a discussion and some thought and some support around that. It's all right for me to say on this webinar that all the evidence we have is that it's safe in every trimester, and I want to state that clearly. But if people are feeling worried during the first 12 weeks, what I would say is, okay, we can deal with that. We can administer the vaccine later. If you are in a group of women who've been invited for the vaccine, what might be really important is to consider something which is an extension of what Jo Mountfield has said. What we do know from confidential inquiry data and from intensive care data is if this infection does affect pregnant women in a worse way, that seems to be particularly true in the third trimester pregnancy. So if you're going to get vaccinated before then. It's really a good thing not to catch COVID in the third trimester pregnancy, relatively speaking.
Okay.
I hope that helps.
Thank you very much. Okay, moving over to Natalie, a question about breastfeeding. Can somebody ask for the Pfizer or Moderna vaccines if they're breastfeeding rather than AstraZeneca? And would you recommend the Pfizer or Mrna vaccine over the AstraZeneca vaccine?
Yeah, it's a really good question, and one that we've been discussing in the group of people interested in breastfeeding medicine, doctors and scientists in the UK. I mean, at the moment, if you're under 30, then it's perfectly possible to have that discussion with your healthcare provider. I don't know if RCOG have added this to their consideration, or if Jo's got anything without landing her in it again. But I think it would certainly be something to think about, but only probably in the first few weeks after giving birth, when clot risk can be a little higher, particularly if mums are immobile after a C-section or so on. So I think that perhaps needs to be some more thought about that, but I'm not aware that there's an edict that people can definitely choose the vaccine at that stage.
Thank you. Jo, do you have anything to add?
Sorry, I couldn't unmute. You'd think by now I'd have got this sorted after a year on Zoom and things, but there we go. So we had in our guidance and suggested that women could ask to have a Pfizer or Moderna vaccine rather than the AstraZeneca vaccine, and certainly in pregnancy that's now been confirmed. I just want to say again about the clots. The clots related to the AstraZeneca vaccine are not increased at risk in a prothrombotic state. What do I mean by that is absolutely when you've had a baby, the most risky time to get clots is when you've just had a baby. And it's much the most riskiest time in your life, basically. But the clots that you get then are not the same clots as the AstraZeneca vaccine gives you, okay? It's an immune response to AstraZeneca, which is more common in women, but it is not the same as the increased risk of clots when you are postnatal. So at the moment, the advice from the JCVI is that you can have any of the vaccines if you are breastfeeding, but we've been pretty clear that if anybody who wishes to have a conversation about which vaccine they wish to accept is absolutely right, that they should do so with their healthcare professional. That is the same for anybody in the population, but we did make that clear in our last statement as well.
Lovely, thank you very much. And if I can come back to Rehan, if we decide to have the vaccine, how much time should be left between that and the flu, and also the whooping cough vaccines?
Well, I think so. I don't know why, but I think the W is silent. I think it's pronounced whooping cough.
It is whooping cough.
But as no one's seen it for generations, no one can remember which is not a bad thing. It's not a bad thing if none of us can remember how to pronounce it anymore. So there isn't any need to have any specific time precautions that we perceive between these different types of vaccines. It's a really good and important question, because the receipt of the flu vaccine, of the whooping cough vaccine, is a routine part of pregnancy care in the United Kingdom. And we strongly encourage women to continue to have these vaccines. But the timing of the COVID-19 vaccine is not necessarily linked to those. So there need be no specific concerns. I do get where the concerns are coming from, but actually it has for many, many years been practiced in the UK to safely deliver lots of different vaccines at the same time. And the time this happened for all of us was in childhood. Well, for example, if you got your MMR. So I don't have a concern about that.
Okay, lovely. Thank you, Rehan. Okay, if I could come to Victoria. I'm concerned about the 1950s, 1960s scandal for thalidomide. How do we know this vaccine will not have a detrimental impact to our fetus? Has it really been tested long enough to guarantee no danger to our baby?
Well, I think this comes back, doesn't it, to what I was saying before about how a lot of people, well, in the USA, 87,000 people now, and also many thousands in Israel and Europe, have had the vaccine. And you're right that, you know, babies whose mothers have been vaccinated in the first trimester, which is when thalidomide was a problem, because that's when, you know, physical development is occurring. Those babies haven't been born yet. But what we have now that we didn't have back in the 50s is scans. We have a scan at 12 or 13 weeks. We have another more detailed anatomy scan at 20 weeks. And no problems have been detected then. So I think that we can already from those say that we're not going to see anything like thalidomide. And also another really important thing to remember is, as I've mentioned before, because of how the vaccines work, we think they don't get anywhere near your baby. We think they don't go through the placenta. So for that reason, again, we have a lot of confidence that we're not going to have a thalidomide style problem happening here.
So we think they don't go through the placenta, but there's no guarantees that it doesn't go through the placenta.
Well, the important thing to say here is that in order to see if something's going into the placenta, what you need to do is fish out the placenta. And in the context of human pregnancy, we're really not going to do that because you continue to need your placenta to look after your baby. But animal work with certainly the mRNA vaccines, which are the ones that we're mainly talking about here, because these are the ones that pregnant people are going to be offered, have shown that these lipid nanoparticles that surround the mRNA, they don't cross the placenta. So we expect the same thing in people. We can't look in people because we're not going to take out your baby and your placenta as part of a study to find that out.
Okay, thank you. Rehan, is there anything you'd like to add to that?
No, I concur with all of that, actually.
Okay, good.
Can I just say one more thing about the gap between the vaccination? I think it's just worth saying Rehan's quite right about there is no reason why you can't have them concurrently, but the current advice is to wait for 7 days between the two vaccines. And that is because at the moment we are still wanting to collect really reliable data about potential side effects to the vaccine. So at the moment, you will not be offered the flu vaccine and the COVID vaccine at the same time, because they're wanting to want to collect the data about any potential side effects, so they can be really clear that there isn't a mixing of the two potential side effects with the two vaccines. So I just thought it's probably worthwhile adding that. So just for clarification.
And while I've got you, Jo, if I could also ask you about the route for pregnant women getting access to the correct brand of vaccine. You have touched on this, but it's a popular question. So if we could just talk about it again.
Yes. So, there are only certain centres that will be having the Pfizer and Moderna vaccine. And I'm afraid because this was only announced on Friday, this will need to be sorted out. And it hasn't been sorted out operationally yet, because but there will be a bit of leeway, because as we know, unless you're in the high risk groups when you already will have been offered that vaccine, it will be rolled out as we go down the age groups, because they're not suggesting prioritising pregnant women any higher other than via age. So this is a piece of work that will need to be sorted with maternity services, because up till now we've just been concentrating on the women at higher risk in the high risk groups. And latterly, we've been asked to identify women who've got a BMI over 40 and who've got gestational diabetes to be offered the vaccine. Now, since last week, it's everybody. And so we need to work with those who are with GPs, and maternity services need to work out how that offer is going to happen if many of the vaccination centres can't offer Pfizer or Moderna. So I'd love to be able to give you the absolute answer, but operationally it needs to be sorted basically, and it isn't exactly sorted. But your local GP, your local obstetrician will know where you are able to access that vaccine if you're at a high risk and need to be vaccinated very shortly. And by the time we're rolling out to the lower ages, this should all have been very much put in place, because it certainly needs to be. But I haven't got the absolute answer for you today, I'm afraid.
Do you think there's an argument, Jo, that pregnant women should be prioritised, obviously, bearing in mind that we don't have the system fully set up at the minute, but do you think there should...
Well, this was I know that this was discussed in great depth at the JC, the committee, where they were considering whether there should be anything other than a rollout down the age group. As Rehan says, it is more of a problem if you get COVID after 28 weeks than under 28 weeks. You are no more likely to get it if you are pregnant or non-pregnant, and overall the mortality is around the same. So I think that's why they've gone for rollout with age. Whether that will be changed in the next few weeks, I don't know, but that's what the JCVI are recommending at the moment, and so that's where we are basically. And I know that might not feel fair, but that's not my decision to make, I'm afraid.
Yeah, thank you. A question for Natalie. Should breastfeeding mothers take the baby's immunisation schedule into account when arranging their own COVID vaccine?
You must have known that was coming next, because that's what I waved my hand about before. It really feeds into the discussion that Rehan and Jo were just having about not confusing the vaccine responses in either mum or baby, and having that clear window of a good week, if possible, to stagger between the schedule of infant vaccinations as well.
Okay. Great, thank you. And there was a question earlier actually that I thought was quite interesting. A woman who was saying she has a 6-year-old and she has a baby and she's breastfeeding the baby. Would it be worth her expressing some milk and feeding it to her 6-year-old son or daughter to get the antibodies?
Yes, well, who knows? And as far as I know, I don't think there's any studies looking at the immediate outcomes on babies who are being breastfed, not just from the vaccine response, but actually their general health. We know that human milk evolved to protect infants from viruses, along with a whole range of other infectious agents. And in fact, bolstering immunity was probably the primary aim of lactation, rather than providing nutrition for growth. We've just published a paper that describes 20 different mechanisms by which human milk protects babies against viruses, and hundreds of different bioactive components within those mechanisms. So there's a huge amount going on. It can't do any harm, is all I can say.
Right.
In New York, there was a piece in the New York Times about women providing milk for exactly this purpose to high-risk individuals.
Brilliant, thank you. Question here for Jo. As pregnant women are going to be vaccinated at the same time as non-pregnant people their age, if you're in the 3rd trimester and you are concerned about contracting COVID, is it worth you perhaps contacting your GP and asking if you could be prioritised for vaccination?
You can ask, but whether they will agree to it in the scheme of things is, given the JCVI response, is quite difficult, basically. Because individually GPs, if you have got increased risk factors, doctors can recommend that you are vaccinated earlier. But if you are somebody who is otherwise fit and well, and your only risk factor that you are in the 3rd trimester, at the moment, the advice will be you need to wait until your age group comes through. And as I say, I'm afraid that's not my decision. That is the decision that the JCVI is. So you can ask the question, but the GPs may, whoever your health professional may say, we can't authorise that because actually that's not the national advice, and they've been pretty strict about the rollout in terms of not offering people vaccines who do not meet the criteria. So you could try and you may get some success, but it's not what the JCVI are recommending at the moment, unless that changes over the next few weeks.
Lovely, thanks, Jo. A question here that's for Jo, and then I would say is also for Danielle. How seriously should we take the shielding in our 3rd trimester if we can't get the vaccine due to our age, weighing up the mental health implications of being isolated? So Jo first, and then
shielding. Actually, no one now is asked to shield. You will recall that everybody has been told they do not need to shield. So what I would say to you if you're in the 3rd trimester is this: you need to be really sensible about what you're doing. The prevalence at the moment is very low in most areas, which is really reassuring at the moment. And that's just because we've come out of lockdown. So you need to really follow the advice. If you, don't mix with people in indoor areas, if you wear your mask, you wash your hands, you stay socially distanced, it's all these small things that add up together to give you the protection that you need about not catching COVID. So if you follow the guidance, then the chances are you will not catch COVID, even in the 3rd trimester. And that's my best advice to you. But you don't need to shield. You don't need to lock yourself away at the moment. You can go out, you can go to the shops. It's just that when you're there, you should socially distance, etc. Do all the things that we've been recommended to do. That would be my advice, because complete shielding is quite difficult, especially if you have other children, etc. It's a very difficult thing to achieve, and is not recommended for anybody anymore.
Okay, lovely, thank you. And then Danielle, if you could just quickly talk about, if you're in particularly in the later stages of pregnancy, and as we've been hearing, that's a slightly more dangerous period. Dangerous is probably the wrong word, but you are more likely to perhaps end up more severely unwell. What do you do if you feel unsafe at work and you don't feel that your employer is looking after you?
Well, the government weren't very good at this right at the start of the pandemic in terms of providing any sort of guidance to pregnant employees. However, halfway through, we got some fantastic guidance that was issued by them, but it split pregnant women into 2 categories. So it split them into up to 28 weeks pregnant and then after 28 weeks pregnant. And I think the underlying principle for both categories was that there has to be a risk assessment carried out to see whether or not there is an increased risk to pregnant employees, which obviously there was. And looked at the measures which could be put in place, particularly for those over 28 weeks pregnant. It said that there had to be a massive emphasis on making sure that the employee could work safely. So things like social distancing had to be put in place. for example. So we were getting a lot of calls at that time for people that worked in the healthcare sector, midwives, care workers, saying there's no way I can social distance. We had a lot from teachers as well when the children were in school saying, I work in reception, you know, we can't socially distance from the children. So we were saying to people, well, you need to go in, make sure that risk assessment is done. If that risk assessment does highlight that there are risks there and those risks can't be avoided, your employer needs to look at ways and means in which they could be avoided. So can you work from home? Could you do a job that doesn't mean that you are having constant face-to-face contact with members of the public? You're not in a classroom full of 28, 30 kids at a time. And a lot of employers were doing that. A lot of employers were sending them home or getting them an office of their own to work in. Where those measures couldn't be put in place, if you are pregnant and your workplace isn't safe, then your employers do have to suspend you on full pay. So it is suspension on maternity grounds. And again, that was something that was happening an awful lot when we were in the height of the pandemic. I think there's been a couple of questions. I've been trying to answer all the employment questions because I know people want the medical advice more than the employment advice. So I've been trying to tick them off, but there was a lot of questions about has the guidance changed for people over 28 weeks pregnant in the workplace, and it hasn't as of yet. So I think if you are approaching 28 weeks and you are in that last trimester, then you do really need to sit down with your employer. If you don't feel safe, explain why and see whether or not there are any measures that can be put in place to make you feel more comfortable. If not, you need to say to them, I need to be medically, put on suspension on full pay. Furlough is also another option that I just mentioned before I sign out. But, furlough is a middle ground that is still available until the latter part of this year. So you could request to be furloughed if it is that your employer can't afford to put you on full pay for that period of time.
Thank you very much. And Pregnant and Screwed has an advice line as well for anybody that has employment issues at work, health and safety related. So give us a call and we can talk you through that. Question for Viki, please. Somebody here who's pregnant had the AstraZeneca vaccine and now wants to know whether she should have her second AstraZeneca vaccine or whether she should perhaps ask to swap to Pfizer or Moderna.
So the first thing to say is that this idea of mixing and matching vaccines, which has come up, is actually being trialled, but has not yet been trialled. So I think we wouldn't recommend that anyone do that. And I think if you go to the vaccination clinic and try to do that, they'll tell you no. But with respect, I'm not exactly sure where the question is coming from. So I'll suggest two answers. Firstly, with respect to this idea about the rare clotting disorder, which I want to echo what Jo said and be clear that it's not the same as sort of normal clotting. It's a very special and particular thing that's going on here. It's not ever been seen in someone having their second dose. And so the JCVI's advice was that if you'd had your first dose, even if you were under 30, you should go ahead and have your second dose. So if you're asking because of that, the answer is go ahead and have your second dose. If the question is, I had my first dose and I've since become pregnant, should I get my second dose? I think the JCVI's advice is, well, now actually quite clearly, yes, you should. But I can see an argument that you would want to have a discussion with your own personal care team, and you might decide that you wish to delay your second dose until after you've given birth, which is what the advice used to be if you got pregnant if you had the vaccine and then you got pregnant. But I would say right now, actually, that probably you would be offered your second dose of AstraZeneca and you probably, I think it wouldn't be a bad idea to take it. I don't know if the JCVI has got quite that granular though yet. I don't know if Jo has a comment on whether I'm interpreting the JCVI correctly there.
Jo?
Yeah, I think you're spot on, actually, Victoria. Certainly the risk of the clots is only been seen with the first dose for the AstraZeneca. So if you've had one dose, definitely you should go and have another one. And if you've already had one, you are likely to be fine to have the second one, quite honestly. So I think carry on with the same vaccine if you've had it, but there are the reasons why the Moderna and the Pfizer were prioritised was because of the extra information that we got about them rather than the AstraZeneca. So I think Victoria's spot on. And as we get more and more information, and the trials are starting with pregnant women finally, then we'll be able to provide more reassurance. But if any doubt, that's why you've got a midwife, an obstetrician and a GP to have a conversation with. That's what we're here for. So please don't hesitate to make those contacts and make use of us, because that's what they're paying us for.
And Jo, this would be another question for you. I am a teacher of 4 to 6-year-olds and cannot socially distance with young children. If I have both doses of the vaccine, would it be safe to go to work with no social distancing after 28 weeks?
I think this is a really difficult question, quite honestly. So we are at the moment in my own organisation debating those high-risk individuals who have not been working on the front line, and they're at higher risk because they're working, potentially could be working with people coming in who've got COVID. And actually what we're doing for the healthcare workers who are potentially looking after patients with COVID is offering them a conversation about how they feel and whether they feel safe or don't feel safe. And if they don't feel safe, that we are certainly not at the moment making anybody come back to work. And at the moment, I think that has to be the standard advice. We are still in a pandemic. Although the vaccination does offer some protection, it is not 100% effective for anybody. There is a risk if you can't socially distance. And so I think after 28 weeks, there is still a conversation to be had with your employer. And it's an individual risk assessment. And we're not changing any of that advice at the moment. I think it's too soon to do so. It may change as we move forward, when we come out of a pandemic, hopefully into an epidemic, but not at the moment. I think you've probably got to err on the side of caution. But it's an individual. It is always an individual choice.
Danielle, anything to add?
No, I think Jo hit the nail on the head there. At the minute, we're still saying to employers that if you can allow your employees to work from home, then do so. Obviously the numbers are still there. The vaccination program's only been rolled out. Since January, there's still an awful lot of the population that needs to be vaccinated. So, as I said, I've been telling and I've been advising employers just to bat on as normal, make sure that any measure that they can put in place is in place to ensure safety of staff, but also, and it kind of ties into that point before about people who are 28 weeks pregnant or above. I think that we should just act on the government guidance as it's been now for a few months. I don't think that there's anything at all that's been shown to prove that shouldn't be the case now.
Lovely. Okay, thank you. I'd like to ask Viki a question about I was hearing this a lot over the weekend, which is why I really want to throw it in there, if you don't mind. People seem to believe that if they have the vaccine while pregnant, they're more likely to miscarry. And that comes from the yellow card data, if I said that right, yellow card data, and some statistics that have come out from there. Could you talk a bit about miscarriage and the vaccine, please?
Yes. So the first thing to say about the yellow card data is it's a little bit difficult to interpret, because unlike the US, we don't every week the US says 87,000 pregnant women have been vaccinated, and the next week you'll come back and it will say 95,000 pregnant women have been vaccinated. So when you look at the data, as I do every week for the US, and you see that there have been at the moment 62 miscarriages reported, you can say, okay, it's 62 out of 87,000 people, and you've got a really good perspective. With the yellow card data, we just have the miscarriage figures. We don't have the how many is that out of figures. But what we do have is the JCVI will kind of periodically tells us what's going on. And so back in February, they said, we've looked at all this data and we're not seeing a safety signal. So it's not happening at a higher rate than we'd expect. And then obviously the statement that they put out on Friday also included a statement that they've been looking at the data and there's no safety signal. So there's no increase in miscarriages. But to go back to the US data, the other thing that the US have that we now have in the UK that is really, really useful is what's called an active tracking study. And we do have some of these in the UK, but they haven't reported yet. And what the active tracking study does is it's V-safe, and they take your details when you're pregnant and they'll follow up with you for regularly after you've had the vaccination to see how you've been getting on. And that means, because a lot of people won't bother reporting a miscarriage, because miscarriages, as we know, are very common, and a lot of people will sort of say, oh, well, you know, these things happen. But with the active tracking data, they're actively saying, like, tell us if anything's happened, anything at all, we want to know about it. And so we have really good data from those studies about how common miscarriages are in people who have had the Pfizer and the Mrna vaccines, and they are exactly as common as they are in people who have not had the Pfizer and the Mrna vaccines. So that's to say that you might get vaccinated and have a miscarriage, but it's the same as you might not get vaccinated and have a miscarriage. You're no more likely to have a miscarriage if you get vaccinated, according to all the safety data that we have, than if you hadn't got vaccinated.
Thank you very much. Question for Rehan. Is it beneficial to the baby to have the vaccine? Is the baby likely to receive antibodies? I guess both in utero, and then Natalie can talk a bit about breastfeeding.
I guess there's a lot we don't know about this, but if you forgive me to answer the question in a slightly different way, if there is one group of human beings who seem to do generally well with COVID, it's probably babies. So we don't perceive necessarily very much in the way of benefit or risk for babies as a result of mums being vaccinated, except this: the most important thing always for the health of the unborn child is the general health of the mother. And so in particular, what I'd like to emphasize is if there are mothers who have been invited for vaccination because they're in a group whereby they might be at risk of a more serious illness were they to contract COVID-19, then ultimately that will be beneficial for the baby. So just a reminder of who those groups are as of the 16th of April. So pregnant women are being offered the COVID-19 vaccination if, for example, and Jo has mentioned this, if they have gestational diabetes. I think it's really important to point that one out, because you don't fall pregnant with gestational diabetes. It's typically only diagnosed at around 26 to 28 weeks gestation. If they have a body mass index of more than 40, and if they are individuals considered at high risk of COVID-19 because of personal factors or health factors, and those include age, which has been mentioned already, but also ethnicity and underlying health conditions. And usually the way that's all calculated together is using Q-risk from Oxford, but as has already been mentioned, sometimes a GP will make a personal decision on behalf of the patient. But really the baby's well-being is so reliant on the mother's well-being that I think it's important that if a pregnant woman is therefore invited for a vaccine, to at the very least take that invitation seriously and think very hard about it. May I just come back to one thing around miscarriage, which was mentioned earlier? Is that all right? So there is British Fertility Society advice on this matter, and it very much concurs with what you've heard. In fact, it goes further. It even specifically says for women who've had recurrent miscarriage and are now trying to fall pregnant again, there's no reason to postpone having a COVID-19 vaccine. And so you can find a lot of really interesting and useful information on the British Fertility Society website for the particular listeners and watchers today who might be seeking fertility treatment.
And you would say as well for IVF, there's no reason, if you're going through IVF at the moment, there's no reason not to have the vaccine as well?
Well, there's no, as far as we can tell, there's no medical reason. So what the British Fertility Society advises, firstly, they don't believe that any of the vaccines can affect fertility, which is the same as the position of the Royal College. If you ask, can I have a COVID-19 vaccine during fertility treatment, and that might be IVF, so embryo transfer or egg freezing or ovulation induction, or even intrauterine insemination, their answer is yes, although you may wish to consider the timing of having the vaccine during fertility treatment, taking into account that some people might get side effects in the first few days after a vaccination, which they don't want to have during the treatment. such as fever or headache or muscle ache. So it might be sensible to separate the date of vaccination by a few days for some treatment procedures, for example, egg collection, so that symptoms such as fever might be attributed correctly to the vaccine or to the treatment procedure. The British Fertility Society don't feel that there's a need to delay fertility treatment until after someone's had the vaccine. In fact, they say the only reason to consider delaying would be if you wanted to be protected against COVID-19 before you were pregnant, in which case you might have to wait for both doses, etc. And they suggest that if you ask yourself, how soon can I have the vaccine after I start fertility treatment, the British Fertility Society's advice is immediately. So I know that that's not necessarily all or most women, but it is a lot of women. And actually, it's easy for their voice to be lost in this conversation. So I'm glad we've had a chance to address those topics.
Great, thank you. I'm going to just, we're getting close to 1:15. I've got two more questions. The first one is a question that I received yesterday. Could the vaccine affect people who have different ethnicities differently? The person who posed the question was a Black woman who was concerned that very few Black women had been through the trial for the various vaccines, and so wanted to understand whether that means that there isn't enough data on how this could impact Black women. Viki?
Well, that's a question that may have been addressed specifically. And actually, I was just in a webinar today with Judith Absalom, who is the person who's running the clinical trial on the Pfizer vaccine in pregnant people. And she was saying that actually they have recruited 10% of their participants in that are Black women. So, you know, it's something where people are making an effort because it could potentially, you're right, be important. But I don't have at my fingertips the data of how many Black women have had the vaccine. But what I will tell you is that when you've got 87,000 people in the United States who've had the vaccine while they were pregnant, a chunk of those is definitely going to be of all different ethnicities, actually. So I don't have the data at my fingertips, but it's something that is being taken seriously in the trials. And if anyone else knows more than me about that, I'd really love to hear it. Oh, and what I will also say, sorry, is that in a lot of the studies that I've read, just tracking people, so quite a lot of immune studies have been done where they kind of take advantage of the fact that people are having the vaccine and they say, okay, we're going to draw a little bit of blood from you before and after and see how your immune response gets on. Some of those studies do report the ethnicity of their participants. Some of those studies do have Black participants. The Black participants actually looked quite a lot, and well, in fact, everyone kind of looked pretty much the same in those studies where ethnicity was reported.
Okay, thank you. Rehan, do you have anything to add to that?
Certainly not from a science perspective. I can't add to that. But I think that, you know, I've spent my career working in East London. So the privilege of working as a doctor in East London is to look after, I'm an obstetrician, so it's women and babies from all over the world and from all ethnicities. And the anxiety I had, because as well as an obstetrician, I was on call for the Excel Vaccine Centre on Saturday, is that we have in East London seen tragedy. We've seen a lot of deaths, particularly in London boroughs of Newham and Tower Hamlets and Barking, Dagenham and Redbridge. And we've seen a good deal of vaccine hesitancy, which is not the same as being an anti-vaxxer at all, and is often has its basis in history and distrust. And we need to take these things seriously. And we need to build or perhaps rebuild trust. There have been some really good initiatives all over the country. And it's important for me as a health professional, my colleagues, to be vigilant for the same hesitancy as a rollout expands amongst pregnant women. That's the only other thing I wanted to add.
Okay, thank you. Thank you very much. Jo, could you just give us a quick summary of, if you're pregnant, the risk and benefit analysis. So for women who don't have underlying health issues, who are pregnant at any gestation, what would you say, how would you analyse the risk and benefits of having the vaccine?
So I think Victoria's already done this right at the beginning, but it's the same thing. You can catch COVID-19. If you catch COVID-19, you can become seriously unwell. You are more likely to be seriously unwell if you're over 28 weeks than less than 28 weeks, but you can be seriously unwell at any point. And there are certain characteristics, such as being from an ethnic minority, that will increase your risks of becoming seriously unwell. If you become seriously unwell, you may well end up in being admitted to hospital. A small proportion will end up in intensive care, and a very, very small minority will die. But for your baby, if you are seriously unwell, if you do end up in hospital, you are more likely to end up being born early. And there are some significant risks around being born early. So although baby may well survive, may well have no problems with actually COVID-19, the risks of prematurity are there. So those are the things to consider in terms of whether you should have a vaccine or not. On the opposite side, yes, having a vaccination is not an entirely risk-free operation. We are really quite confident that there should not be risks in terms of development to the baby because of the sort of vaccine that it is, and we've got extensive experience with other similar type vaccines. But you could have a reaction to the actual vaccination itself, and for some of those that are very rare, you could get that if you were pregnant as well. So it is an individual decision, rather like Victoria, and if you ask me what my personal opinion is, and if I ask any of my family whether they should get vaccinated, I absolutely say go get vaccinated. We're in a pandemic. It's not going away anytime soon. And if you haven't got any other risk factors, I personally would recommend that you consider going having it. But please go and discuss that, weighs up the pros and cons. There's some really excellent information on our website and on the RCM website about the benefits versus the downsides of vaccination and how you make that choice for yourself, because it is very much a personal and an individual decision. So please do use those resources, but above all, use the resources of the healthcare professionals and go and discuss that if you have anxieties. So hopefully that's a helpful, quick summary.
Thank you. And just to finish off, if Vicky could just give us a quick, anything to add from what Jo said, and then Natalie, if you could give us a quick risk and benefit analysis for breastfeeding, and then we're done.
I have nothing to add to what Jo has said, except to say, which I always do, that we're very focused at the moment on COVID-19 vaccination because we're in the middle of a COVID-19 pandemic. Don't forget about your routine immunisations. You will be offered flu, you will be offered whooping cough. We know that those are very beneficial for you and your baby, so do get them. And when you have your baby, do go get your baby's routine immunisations that will protect your baby.
Thank you. Natalie?
Nothing really specific to add, except to say that I think what this has shown from my point of view is the data gap that's clear for the lack of trial data on pregnant and lactating women, which was understandable in the first instance, but there was a lack of will on the side of the manufacturers to address that. And really we're hopeful that this will shine a light on that, and the fact that it's true for every pharmaceutical agent that's produced and isn't giving women the evidence, or indeed healthcare providers the evidence to help make that risk benefit analysis, which is so crucial.
Thank you very much. I'm going to hand back to Stella. Thank you everybody for answering the questions so thoroughly. I think that was a really good summary. I've certainly learnt a lot. So.
Hello everyone. I'm hoping that this works. Just putting in this. So thank you so much to all of our panelists this evening. I mean, I've learned loads this evening, and also just as a pregnant woman, I feel much more reassured as well about some of the choices facing me. As a politician, I've got my to-do list from what you've all been talking about this evening. So let me just make some pledges to you all. First of all, I absolutely want to take up Jo's point about the operational issues about this, because it's no good being told that we could now possibly have the vaccine if, because of the nature of the vaccine and particularly the way in which it's stored, it means that actually that's not going to be an option for very many pregnant women for some time, especially given some of the questions about what gestational period you might have it. So on Friday, when we have our regular meeting with Nadeem Zahari, you can I promise you, Jo, I will be nagging him about the operational rollout and making sure that pregnant women are being thought of, to make sure that when we do get to that age group that they can, well, and as people are indeed eligible, that they can get access to it. Secondly, I'm also going to keep raising this issue with the JCVI about the rollout age. I take your point about whether it's done on gestation or whether it's done on age group. Clearly, that does sound like something where we need a bit more clarity about whether gestation should be a factor. So I'm going to keep asking and pushing for them to look at that question. Thirdly, I'm going to pick up the point about information. Obviously, we've got loads of people here who've shared lots of really information for you. My office will commit to making sure we get out to everybody all the links that people have been sharing with us. And I'll say to all the panelists as well, if you've got any other information you want to get out, please do send that to us and we'll make sure we get that out to everybody who signed up for this evening's event. Fourthly, absolutely thank you so much to Danielle for being here as well, because I think the employment side of this is really important, and it does sound like actually, especially as the guidance is changing, we probably need updated employment guidance too for people. And then finally, obviously we organised this seminar, and just want to say thank you so much to Joeli, who has been absolutely brilliant. But one of the things that Joeli has also been working on, and one of the things unfortunately this has clashed with, is a really important debate taking part in Parliament tonight, led by my colleagues, particularly Marsha Cordova, on the 5 times campaign, which is about the fact that Black mothers are 5 times more likely to experience death in childbirth in this country. And it's a national scandal, and it should be something that there is a national action plan on. So what I'm going to ask every one of our panelists to do is we're going to take a photo to show that we are showing some solidarity to all the women tonight campaigning for the 5 times campaign as well. That's all right. So I'm going to remove all the spotlights and ask the team if they can take a picture of everybody doing the 5 times. Brilliant. Everyone's got their hands up. Yeah, Rehan, you have to get your hand in the picture. Perfect. Fantastic. Okay, hopefully everyone got that picture. It's a really important campaign. We'll circulate the details of that as well. Really important that we're speaking up for pregnant women around the country, and particularly some of those others. And there's clearly an issue here about the data as well for Black mothers and the vaccine as well. So I'm going to pick that up with the ministers. Can I say a massive thank you to everybody who's been a panelist this evening for all the answers that you've given. It's incredible to look at all the information already on the Q&A. Fingers crossed this has been streaming on my Facebook page, which means that we've got a video of it, which hopefully Pregnant and Screwed will be able to share with people as well, so that you can keep sharing the information that you've seen this evening. Can also say a massive thank you to our 2 interpreters, Bibi and Francis, who I think you'll agree have done a brilliant job this evening of keeping up with us, and hopefully the spotlighting worked for some people. If you've not heard the information that you want tonight, I would encourage you to go and talk to your local GP. Please don't email my office, because I'm not the right kind of doctor to answer the questions and I don't want to get it wrong, but I recognise there is a need for more information. So my final commitment to you is I'm going to keep nagging the ministers to get that information out about what's happening in pregnancy, breastfeeding, fertility treatment, and in terms of the vaccine longer term for women, because I think there is a real need, and I think this session and the fact that thousands of people turned up showed that. With that adieu, we're going to finish on time, which is even better for events more than else. I want to say a massive thank you to everyone who's taken part, who's asked questions, who's spoken this evening, and please do share this information. You'll find it on my Facebook page, you'll find it on Pregnant and Screwed. Please do follow Pregnant and Screwed and support them. And as I said at the start, for goodness sake, please do go and buy Joeli's book, because it really does make a difference to have organisations like Pregnant and Screwed helping and supporting the policy making process. Okay, thank you very much, everybody. Bye bye.